IAGES. And thanks for joining today, the week 3, day 5 in Docplexus rerun of the INDO-UK Surgicon. You all may be wondering, I'm sure you're all passionate viewers, why we are doing a rerun of this for the time being. This is for two reasons, let me tell you. One, of course, when we had this program last October, it was going parallelly 4 halls, 2 days, non-stop from morning till evening. And it was watched by viewers across the globe. And people in UK and US, especially in the morning sessions, they were not able to watch. And people in sitting in endoscopy sessions missed the interesting topics and debates in the other sessions. So we thought, Dr. Raman Goyal, Pavanindralal, myself, and also our current president, Sunil Papat, all the EC felt, I think we have so much of academic materials out there, we should share with them. And I'm sure 6 to 7, the next 1 hour will be well spent by all of you. Because this week we have an important session which is close to my heart, that is endoscopy session. Because even though we are all laparoscopic surgeon, most of us, endoscopy, all I'm sure you will agree, it is an essential part in our day-to-day practice. I won't say it is just an optional. We can't just do a diagnosis, because I'm sure the day is not too far. Most of the therapy is going to be in the endoscopy platform, because the way the advancements are happening in endoscopy, 50 to 60% of the procedures are going to be done in the flexible endoscopy platform. That's why we felt in IAGES the importance of this. We are already running programs like the endoscopic basic training program, that is EFIAGES, advanced training program, that is 4G, already year 3. And this, the last 1 year, because of the pandemic, we have been doing it as online. And based on that, and also because of the need for this, like SAGES, what they do, the importance of the endoscopy, they have understood. European Congress, UK, Australia, wherever you go, the surgeons, we used to do a lot of endoscopy. Now we realize the potential and importance. We started learning. So the last 5 days, from Monday to today, we had quite a run of all the endoscopic topics we discussed the last year. Let me take you to the Monday, for example. We had expert talk, thanks to Dr. Goindraj. He said clearly, whenever we have, for example, any leak because of surgery, anastomotic leak is a nightmare for any surgeons, all of us know. Those days are gone where when there is a leak, there is a significant morbidity and a sizable mortality. But now, thanks to a lot of non-invasive or endoscopic procedures available, like self-expanding metal stents, for that example, a classical example, whenever you have a perforation because of either endoscopy induced or a perforation following a surgery or a leak following a sleeve gastrectomy. So various examples you can quote. So they're all, you can cover that area very nicely by what we call a fully covered self-expanding metal stent. He has given an extensive review of this important topic, and I'm sure this is the one you need to look for, and this is a perfectly feasible procedure in the hands of surgeon. Next, of course, is Dr. Vijay Borgankar, our EC member. He clearly exhibited the algorithm, how you manage next time when you have a patient with a large, massive lower GA bleeding. Because all of us know how to manage a patient with hematemesis or melena, which are the symptoms of upper GA bleeding. But lower GA bleeding is less common and sometimes more challenging for us. So he gave a nice algorithm with the case capsules and the importance of this colonoscopy and the importance of angiography and the role of enteroscopy and what is the tiny importance of the capsule colonoscopy. All those things nicely enumerated in this 20 minutes lecture. I'm sure if you missed this one second time, you're always there. You can go back to Docplexus or you can come back to our IAGES YouTube. It's there lying for you to have another look at it. Of course, we had the next important thing you like to see is Dr. Vipul Roy telling you the importance of endo ultrasound investigating various lesions in the pancreas. because pancreas, which is in the stomach bed, if it is harbors a cystic lesion or a small solid lesion, there is always a dilemma. What investigation you do after your ultrasound or a contrast CT? Because if you do an ultrasound, especially endoscopic ultrasound, it will be able to clearly characterize the lesion exactly. And also it will be giving you an opportunity to take either a fine needle aspiration cytology or a true cut biopsy, so that end stage and also the nodal status and the tumor status also can be seen. And also you can see the operability. There are a lot of information you gain by the endo ultrasound. So he has enumerated with a plenty of cases, and it is a very, very treat to listen to. Of course, the one of the important lecture I listened in the last 2 decades is one by Professor Hendrik from Spain. He actually gave you a fantastic navigation across the small bowel by what we call the double balloon enteroscopy. The features are so good. It 10 minutes. I wish he had taken more time to describe the potential of this diagnostic and therapeutic enteroscopy. Very nice one. I'm sure you will all enjoy it. The day 2 this week, we had what we call the master videos from 4 masters across the globe, 2 from Malaysia. The Roslani April, she actually gave a vivid description how you manage nowadays a colonic leak. I'm sure the VAC therapy is a in thing for various situations, and she clearly exhibited in her own experience how it can be effectively useful in this situation. And Dr. Murugan from Malaysia, he said all the tricks he had in his sleeve to navigate his ERCP scope in an altered gastric anatomy. But I think the most important thing for all of you, I would say, is practically is one by Dr. Rajshekhar, our ASI chairman, Tamil Nadu now. He gives vivid description of how safely you remove a foreign body. Because when you have a foreign body in the esophagus, lying for more than 24 hours, it is an emergency. But if it is something like a button battery, it is a very risky thing. Sooner you take, it is better. Otherwise, chemical esophagitis, perforation can happen. So he gave an importance of the urgency of removing a button batteries in the child, in the esophagus, also in the stomach, and how to remove them, either using a Dormia basket or a Rothnet, and then safely remove by using a small, like a funnel hood at the tip of the endoscopy. All those tricks, I think one has to have in their sleeves in order to treat these common problems of either a chemical foreign body, sharp foreign bodies in the esophagus. Then we went on to the third day, that is on Wednesday, last Wednesday, we had the panel discussion, which is a very important discussion. I'm sure you would have liked it. I was able to connect to our Satyapriya, our Mr. Colonoscopy from West Bengal, along with our father of endoscopy, Professor Krishnarao from Chennai. Both of them, actually, they were across the globe. We had the Aurora Prayer from the USA, and then the SAGES president. And we had a couple of my colleagues from UK, Professor Ravindran from Edinburgh, Bala from Midlands. They all joined to discuss how to train the surgeons in endoscopy and what's happening in SAGES and what's happening in UK by JAG, the Joint Advisory Group, and what we can do in IAGES or for that matter MCI. So we said we need to improve not only the technical aspects or technical skill training, but also the cognitive skill training. And as I said earlier, we have courses lined up. I'm sure you can very well go to www.iags.in to get to know more about this endoscopy training for surgeons by IAGES. Join if you're interested. Yesterday we had a debate, very interesting one. John Tanakumar, our senior advisor from IAGES from Coimbatore, he actually moderated a session. It was a big fight between Dr. Kanagavel, who was supporting the importance of the lap heller, which is the bread and butter for all of us. Of course, a person from Pune, Dr. Amol Papai, he was telling and defending that poem is the future. That was a very, very interesting thing. But of course, we all have to agree. As I said, endoscopy is going to be the future. The poem already proved it stands. Of course, steep learning curve, need for advanced equipments and training is the only hurdle, but I am sure time is not too far for all of us to learn not only the lab hellas, but also go for poem or what we call a poem plus, where even endoscopically one can contemplate doing a fundoplication. You wonder how? Please go back and watch this debate. It's quite interesting, fact filled, and I'm sure you'll be thrilled to watch again. And today, I'm sure I will be witnessing our one of the icing on the cake today, Professor Mike Griffin from Newcastle, President, Royal College of Surgeons of Edinburgh. Because of his enthusiasm, and of course from our President, Dr. Raman Goyal, Pavan, we were able to bring both RCS, Edinburgh, and IAGES together on this platform. And this is, I'm sure, is one of the topic close to his heart. How you manage a patient with early gastroesophageal cancer endoscopically, like endoscopic mucosal resection. So he was giving all the evidences. I'm sure the next half an hour is going to be very fascinating and you will be enjoying it. But as I said earlier, I'm quite happy to take any questions. Please post it either here as a comment or questions. I'm sure the team Docplexus will direct it to me. I'll be able to address them as soon as I can. In the meantime, as an organizing secretary of IAGS 2021 at Coimbatore on 6th May to 9th May, this go if provided that COVID is going away and all of our medical professionals are getting vaccinated and are ready to come, the first on-site physical conference, that is what we call the post-COVID discussion conference, happening in a very safe environment in Lee Meridian Hotel in Coimbatore for 4 days of academic in 4 different halls. I'm sure you'll see with so many of the delegates. Already we had 400 registrations. Registrations are pouring in and looking forward to meet you. I'm sure you will experience the Congo hospitality from us. Till then, bye-bye now. Enjoy the rest of the day. Thank you. And let us move on to the next one. As a Indo-UK, we are having the president of the Royal College of Surgeons now coming from the UK, and he is going to join Professor Griffin, and he is going to share his knowledge. This is his topic, endoscopic mucosal resection of early esophago-gastric cancer. So I'm sure looking at the results we see from the Newcastle, both from him and his junior colleague Arun Emmanuel, I think they have a voluminous study on this, and we are looking to hear about him and also his presentation today, sir, and to do this and also to present and introduce our Professor Michael Griffin. I request Dr. Professor Krishna Rao sir to read the citation and do the honors for him, sir. And also, let us hand over both the citation and also the presentation later as a hard copy by post. Thank you. Over to you, sir.
Thank you, Ishwar. Mr. President, chairpersons, ladies and gentlemen, it's my privilege to introduce Professor Selwyn Michael Griffin, President of the Royal College of Surgeons of Edinburgh, deliver the presidential oration during INDO-UK Surgicon, IAGES Royal College of Surgeons of Edinburgh Collaborative Conference 2020. He was born in Newcastle upon Tyne in 1955, qualified at the University of Newcastle upon Tyne in 1978, trained in surgery in the same city, Carlisle, and in Hong Kong. Professor Griffin is a consultant esophago-gastric surgeon at the Royal Victoria Infirmary in Newcastle upon Tyne. His clinical and research interests have been focused on early diagnosis and radical treatment of esophago-gastric cancers. He was instrumental in developing the Northern Esophago-Gastric Cancer Unit in Royal Victoria Infirmary, which is now the largest in Europe and North America. He was awarded an OBE by Queen of England for services to cancer healthcare in 2013. He is a council member of the Royal College of Surgeons of Edinburgh since 2009 and was chairman of the Joint Committee for Intercollegiate Examination, JCIE, and professor of gastrointestinal surgery at the University of Newcastle upon Tyne. He served as president of Association Upper Gastrointestinal Surgeons of Great Britain and Ireland between 2004 and 2006. Professor Griffin is a president of the Royal College of Surgeons of Edinburgh since 2018. He has published widely in the field of esophago-gastric surgery and has held visiting professorships in United Kingdom, Europe, and Asia. He has a keen interest in sports. He has represented Scotland in rugby at international level and is a passionate and unwavering fan of Sunderland Football Club. Mr. President, it is my privilege and pleasure to present to you Professor Selwyn Michael Griffin to deliver the presidential oration on endoscopic mucosal resection of early esophago-gastric cancer during INDO-UK Surgicon conference on this day, the 15th of October 2020, for your honors.
Thank you, sir. Thank you, Professor Krishna Rao. Let us listen to Professor Michael Griffin. Over to you, sir.
Just wait to allow me to share my screen. There we are. Right. Well, thank you very much for that introduction. I noticed the smiles when you spoke about my support for Sunderland Football Club. They're not doing very well at the moment. Either way, it is a delight to address this august organization. Just very sad that we didn't manage to host you in July in the lovely summer that we had up in Edinburgh in Scotland. But this virtual conference is a great alternative, and I suspect has attracted many more participants than would have been present in Edinburgh. It's lovely to be here. I'm going to talk to you about the last 10 years of managing esophageal adenocarcinoma, particularly early disease. As you may have heard, that Newcastle has one of the highest incidences of esophageal adenocarcinoma in the world. As a result, we have one of the biggest units, esophageal cancer units in the world as well in Newcastle. And very proud that we have a large and effective team. And I think Arul Emanuel, one of my colleagues who leads the unit now since I became president of the college, will be talking to you about minimally invasive esophageal cancer surgery in due course. So a little bit about endoscopic treatment for esophageal adenocarcinoma. Essentially, there are two endoscopic treatments that are available for esophageal adenocarcinoma. Endoscopic mucosal resection and endoscopic dissection, formal dissection. And they are accepted now throughout Europe and North America as treatments for early disease. The problem, however, is that still there is limited data about the incidence of nodal metastases in early disease, particularly in submucosal cancers. And we have published, and so have Brisbane, under Mark Smithers, has published significant numbers of cases of early disease to quantify the nodal metastasis risk, and I'll come on to that later. But so there are still many unanswered questions that patients might ask us about the risks of leaving disease behind when being treated endoscopically. And of course, there's also the concerns about histopathological interpretation, the limitations of EMR, and in particular, the interpretation of resection margins. The principles of any cancer treatment pertain to surgery and to endoscopic treatment, and that is the eradication of all involved tissue. The crucial things are to minimize operative mortality, a real scourge during the early years of esophagectomy, and to minimize the morbidity. And it's the morbidity that's significant with esophagectomy. And again, we need to preserve the quality of life. This can only be done and assessed appropriately if the disease is staged accurately. Now, I put up this slide, which is a little bit historic, but it's important to make a few points. These are all published papers in the early years of endoscopic resection. And I refer to Tom DeMeester's paper that a biopsy of adenocarcinoma without any visible lesion on endoscopy is always mucosal disease. We are published many years ago about a biopsy of a high-grade dysplasia with a visible lesion in a Barrett's esophagus almost always means it's cancer. And Hubert Stein published that a biopsy of adenocarcinoma with a nodule endoscopically means it's likely to be submucosal disease. The more likely that you have submucosal disease, the more likely you are to have nodal metastases. And also, Jack Bergman published that endoscopic mucosal resection allows accurate T-staging, and it is the most accurate way to stage early disease, is to take it out and look at it under a microscope. And that potentially this provides definitive treatment for intramucosal disease. The reality is that endoscopic ultrasound is very poor at staging T-stage in early disease. The other thing to remember with cancer within a Barrett's esophagus is that it is likely to be multifocal. And up to between 20 and 60% of all patients who have intramucosal cancer have more than one site. The real issue is predicting lymph node involvement. And we know that there are limitations with CT. Endoscopic ultrasound is better for assessing lymph node involvement, but the reality is lymph node involvement, if it is there in early disease, means that that patient requires an esophagectomy and a nodal clearance rather than endoscopic treatment. So what are the risks? Clearly, with high-grade dysplasia, there is no risk of lymph node metastasis. In all the published literature, including our own, the likelihood of nodal metastasis with intramucosal cancer is vanishingly rare. It is between 0 and 2%, but that we in Newcastle have only seen one patient ever with true T1A disease who've had a nodal metastasis. However, for T1B disease, it is much higher, and that is important. And before we go on to look at the data, endoscopic treatments are complicated. They're not easy. And certainly there is a learning curve in performing these procedures. And ESD in particular is a very difficult procedure to do. And it's impossible in the Western patient without giving a general anesthetic. Whereas endoscopic mucosal resection can be managed under sedation. Clearly, as I say here, it is operator dependent, and all the protocols for doing these differ between endoscopic units. And I'm not going to go through our own protocol for time constraints. The other issue is that histopathologists may not be absolutely certain about their diagnosis. And of course, any one histopathologist may interpret things slightly differently. And the one thing that we do know is that endoscopic tools can't differentiate between T1A disease and T1B disease. What we also are aware, and that we have to consider with all of this, is that you may take out what you perceive to be the lesion, but there is more extensive disease underneath. As I mentioned before, it's often multifocal, and certainly if you have got nodal metastasis, EMR does not always solve or cure the problem. What we do know is surgery is a very good way of eradicating the problem, and it's much safer now, and it provides a reasonable quality of life. So if you look at this, surgery versus endoscopy for dealing with early disease, are we able to deal with understage disease with surgery? Of course we are, because we take out the nodal metastases, but with endoscopy we don't. What is the peri-procedure mortality? Well, in most units now, certainly our own unit, surgery is down to well under 2%, and for endoscopy it should be near zero. The recovery time, however, is different, and this is where quality of life comes into play. Recovery time is up to 9 months with surgery, and it's literally days after an endoscopic resection. The short-term oncological outcomes are excellent with both techniques. The medium-term oncological outcomes, perhaps with endoscopy, there is a 30% local and metachronous recurrence rate, but that does not prevent further endoscopic treatment, provided there's no nodal metastasis. And of course, we're still unclear about the long-term outcomes with endoscopic treatments. Surgery clearly is not suitable for unfit patients, frail, the very elderly, whereas endoscopic treatments may well manage that disease quite well. And if we look at the data, this came from Mark Smithers' unit, one of the early big series on surgery and early adenocarcinoma and the incidence of nodal metastasis. You can see that there is a significant incidence of nodal metastasis with submucosal disease. Very important. Our own results here in front of you, we published in the Annals of Surgery some 9 years ago. And you can see the incidence of nodal metastasis with submucosal cancer. There were none in the series with intramucosal cancer. So we have got to consider this issue of submucosal cancer. And broadly speaking, across the board, with results that are published in the world literature, there is around about 10 to 20% chance of nodal metastasis with submucosal adenocarcinoma. If we look at our series there that I've just presented to you, and you look at the cancer-related deaths, and there were 3 in that series. One patient who was operated a long time ago with T1B SM1 disease, he developed a Neo-Barrett's esophagus, and he represented 7 years after the original surgery, and he developed a T4N1 cancer in that Neo-Barrett's after the original esophagectomy. So this is at the suture line, developed a Neo-Barrett's, and then presented very late with a further cancer. So a patient died 7 years after his esophagectomy for a T1B submucosal disease with nodal metastasis, and he represented with bone metastases. We thought this may have been prostatic, but didn't have a post-mortem, so we're not absolutely clear whether this was secondary disease or whether it was prostate cancer. The third patient presented and had an esophagectomy in 2007, and 2 years later represented with extensive metastatic disease, liver, bone, mets, even scalp metastases. And this was a submucosal cancer with 3 nodes positive. And interestingly, 2 of those nodes had extracapsular spread. So overall, the survival was nearly 80%, with disease-specific survival of 92%, with a less than 2% hospital mortality. So surgery does well. And if you look at those results in the table form, there they are. On the right-hand side, you see the cancer-related survival, which is up to 10 years, is approaching 90%. So if we look at the results that we have had in over 600 patients, over 2,000 actual resections for patients with intramucosal cancer, submucosal cancer, as well as dysplastic lesions. The resection margin positivity is very high for low-grade and actually high-grade dysplasia. Interesting, and I'll come on to that. And so it's very difficult to understand what is going on at the margin. We all know what's happening when we do a esophageal resection at the margins, the circumferential margins, as well as the longitudinal margins. But do we really know what's going on after an endoscopic resection? And the histology is often difficult to interpret, and this gives us a difficult decision to make. The techniques, we've mentioned ESD under a general anesthetic, but EMR is, there are two ways: suction cap and multiband mucosectomy. And we favor the suction cap technique, and we have championed the cause of circumferential biopsies. And just to give you an indication of this, I think it's important that we do these biopsies post-resection, that we take biopsies from around where we have removed this, and we go all the way around the resection. You can see the resection is at least 50% of the circumference on this patient that I did quite a number of years ago, 8 or 9 years ago. And we go right the way around, taking biopsies to make sure that we know what we've left behind, because that is equally as important as what we've taken out. And these are a summary of those cases over the 10 years from 2008 to 2019. And there were 527 patients who underwent esophageal endoscopic resections. And if we go through these patients, you can see some of them were done for low-grade dysplasia, high-grade dysplasia, 172 for intramucosal adenocarcinoma, and 38 for T1A. And T1B, there was a very low number of T1B and quite a few number of patients with neuroendocrine lesions and squamous cell lesions. Although our view is that squamous cell cancer in the West is not a good indication for endoscopic treatment because of the multifocality and the submucosal nature. So what indications for potentially curative EMR in adenocarcinoma in T1A, provided there's no lympho and there's no ulceration to the original lesion, and that the differentiation is not poor. For T1B, it's a much narrower indication: patient choice, patient fitness if they are not fit, and all the other reasons that we have for T1A. I think that the way to look at T1B disease and the decision-making process is that, yes, there may be a 10 to 20% nodal metastasis rate, but in an elderly patient, you could look at it the other way around and say, well, an 80 to 90% chance of not having nodal metastases, which would therefore favor somebody in there who is frail or elderly. So if we look at EMR for esophageal adenocarcinoma, these are planned curative treatments having discussed in the multidisciplinary team meeting. And the site of the EMR for esophagus, 138 patients. And you can see the final histology for all of these. T1A, M1, 10 disease. This is going down to the first mucosal layer and going down to the third mucosal layer, 67 patients. There were 23 patients in the T1B group, again with submucosal disease. The complications were relatively small for esophageal EMR. There was a 5% bleeding, post-endoscopic bleeding rate, which was managed exclusively by endoscopic treatments. They did not need to go to theatre to stop the bleeding. there was a small incidence of perforation, but none of those patients in the esophageal. So if we look at those patients who underwent EMR for diagnosis and potential treatment, but then subsequently had either positive margins or submucosal disease, 49 of these patients subsequently went on to have an esophagectomy. And this is the histology that subsequently we discovered having had the esophagectomy. And you can see that out of those 49, 44 were node negative, 4 were node positive N1, and we had 1 patient who had N2 disease. And if you look at the survival of those patients, one of those patients had a total gastrectomy, because the lesion straddled the OG junction, and that patient lived for 5 years without any problem, did not die. And if you looked at those undergoing subtotal esophagectomy, you can see that the outcomes were approaching 90% at 5 years. If you look at the other treatments that were used in these patients, particularly the frail patients underwent brachytherapy by choice and radiotherapy. But if you look at the important group, which is the EMR group, you can see that their overall survival was again 90% at 5 years, and really no difference between them and the esophagectomy group. I thought it would be interesting to finish off with just 3 examples of the difficulty that we have in making a decision about how to treat these patients with early esophageal adenocarcinoma. This is a patient A, has an EMR, has 2 EMRs at the same time. The first EMR has a submucosal cancer, T1B, down to the second submucosal layer, with lymphovascular invasion, and it looks as if the excision is complete on histopathology. Our circumferential margins, our circumferential biopsies were clear. The second EMR had low-grade and high-grade dysplasia at the margins. And so this patient, therefore, the decision was to take the patient to theatre and do an esophagectomy because we had high-grade dysplasia, multifocal disease, and the final histology was, as expected, T1B, SM2, but 3 out of 59 nodes were positive. So if we had carried on with that, nodal metastasis was there and the patient would not have been cured of their disease. The second patient had 2 EMRs, poorly differentiated adenocarcinoma right at the OGJ. It was the mucosa and it was infiltrating into the submucosa, and this was T1B down to the first submucosal layer. There was lymphovascular infiltration, and biopsies from the first specimen indicated high-grade dysplasia, again at the circumferential margins. And now, interestingly, the histology was that there was no disease left in the esophagus, but nevertheless, there were 3 out of 49 nodes were positive for metastatic disease. So once again, this patient with submucosal cancer would have been left with nodal disease if they'd been managed endoscopically. And the third case, interestingly, high-grade dysplasia and submucosal cancer, once again, T1B down to the third layer, completely excised, circumferential margins showed no evidence of high-grade dysplasia or cancer. This patient underwent an esophagectomy, and because it was T1B disease, there was no cancer in the specimen and none of the nodes were involved. So again, we over-treated this patient because the patient had submucosal cancer. We thought that there was a chance of nodal disease and the patient was fit and healthy. As it happened, they would probably have done well with endoscopic treatment. So these are the dilemmas that we have. And so I would conclude that EMR is an established technique. It's safe, but it has to be done with surgical precision, oncological and surgical principles, not done without circumferential margins, for instance. We believe that adenocarcinoma that's T1A is suitable for EMR in patients without multifocal disease, but there's a significant risk of lymph node metastases once the submucosa has been breached. There's still a lot of questions that remain to be answered regarding what is left behind in terms of nodal disease, and that decision-making process is difficult. But nevertheless, we should not forget that surgery still has very good long-term results with intramucosal and submucosal cancer, and particularly with minimally invasive techniques, this is becoming less morbid. All patients have to be discussed in the multidisciplinary team meeting because informed consent is crucial. And with these difficult decisions, it's very difficult discussion about consent. So shared decision-making is essential. Patients need to know what's going on. And I would urge everyone who is doing these procedures to continue to report their outcomes, because we've got to get more information such that we can make the right decisions. Thank you very much for asking me to address this august group today. I've enjoyed it very much. Thank you very much.
Thank you, Professor Griffin. That was a wonderful presentation. Everyone thoroughly enjoyed. I think early esophageal-gastric cancer, especially esophageal cancer, even in our country, thanks to the image enhancement technology, magnification, improvement of the accessories and the training, it is eminently treatable by endotherapy. That you proved it, and we support you with our group here with the Krishnarao sir, the endotherapy, and we as a team, IAGES is actually doing the structured training of endoscopy for the surgeons in the last 4 years, having trained 650 people, both in the advanced and the basic training. They are all sitting and listening to your talk today, and we are very, very proud to have you with us. And thank you once again. And to do the laurels, I request Professor Farooq Afzal from Pakistan to share his thoughts and also give the formal vote of thanks. Over to you, sir.
Thank you very much, Professor Michael Griffin. We really enjoyed your talk. I think the message you conveyed is that surgeons should have an endoscopic skills. We have moved from open surgery to laparoscopic and to endoscopy and now to robotics. So these 4 skills, I think these skill sets should be part of every surgeon's tools. Great talk. You are very lucky that you have that. Unfortunately, in our setup, we have very advanced disease, so we probably have to dream about these lesions. In fact, I really thank the IAGES and the Royal College of Surgeons of Edinburgh. I'm one of the fellows, a proud fellow, and it's a pleasure to see you there. Thank you, Dr. Raman Goyal and everyone. I think really remarkable 2 lectures, and I really am thankful for everything. Thank you very much.
Thank you, Professor Farooq Afzal. Thank you, everybody. I think we close the session. We'll move